Assalamu alaikum wa rahmatullahi wa barakatuh. This is Khalid Alnajjar, and I will be explaining today about the anatomy, histology, and physiology of both the thyroid and the parathyroid glands. Down here is my name and my email and my phone number in case you had any question about this lecture, about this block or any other block. Please don't hesitate to contact me. I will be more than happy to answer you and help you, inshallah. Of course, I will start explaining about everything about the thyroid and then the parathyroid. To kick off, like this panel. But to kick off, let me explain, let me briefly introduce you to the thyroid gland anatomically, and then dig into the physiological aspect of it. So as you can see here, the thyroid gland this is the shape of a thyroid gland. It's not a small gland. It consists of a right lobe and a left lobe, and in between is the isthmus. Okay, and in some people there is a third lobe which is called the pyramidal lobe. It's this part. Okay, around this around the thyroid gland or encapsulate it something called pretracheal fascia, which is it's external to it. It's a false capsule which encapsulates it and is called the pretracheal fascia. Now this fascia is connected directly to the trachea or to the tracheal ribs, and this is the reason why when someone swallows, the thyroid gland moves up and down with the swallowing. Okay. And why is this important clinically speaking? This is because if there is a swelling in the thyroid gland, how will the doctor differentiate and tell whether this swelling is from the thyroid gland or from somewhere else? It's by asking the patient to swallow, and if the swelling moves up and down while the patient is swallowing, then this swelling is from the thyroid gland, because as I said, the thyroid gland moves up and down with the swallowing because of its fascia being connected to the trachea. However, if the swelling is not moving with swallowing, then this is not the trachea. This is not the thyroid gland. And this is just a picture showing the surface anatomy of the thyroid gland. This is the thyroid cartilage. Okay, it basically lies under the thyroid cartilage in between the carotid arteries. The upper lobe, you can anatomically divide it into an upper lobe and a lower lobe. The upper lobe just lies surfacely speaking, the upper lobe lies at the level of the oblique ridge of the thyroid cartilage. This is the thyroid cartilage. This is the oblique ridge. This is where the upper lobe lies in, and the lower lobe lies at the level of the sixth tracheal ridge. Count six tracheal ridges, and then that's where the lower lobe lies, and the lateral parts of the thyroid gland lies in between or very close to the carotid arteries on the left and on the right. Right. Let me quickly talk about the thyroid gland relations, or its relationship to the to objects, or so not objects, organs surrounding it. But let me first orient you to these images. This image is first of all, this is the thyroid gland. Okay. This is the thyroid gland, and this image is showing you the thyroid gland just directly under the skin. Okay. Because it lies under the muscles. However, this picture is just without the muscles, so the muscles dissected. Okay, as you can tell here, the thyroid gland sits on top of the trachea and the esophagus. So we can say the medial surface of it is lapsing on top of the trachea and the esophagus. The lateral parts, the lateral or the anterior part, look at it here, the anterior part and the lateral parts are covered by the muscles. Which muscles? They are the sternohyoid muscle and the sternothyroid muscles. Those are in direct contact with the lateral and the anterior surfaces of the thyroid gland. The posterior surface of it is related to the carotid sheath. This is the posterior surface. This is the carotid sheath and the carotid arteries mainly, and the internal jugular vein. Okay, and now to the blood supply. The thyroid gland is supplied by two major arteries, the superior thyroid artery and the inferior thyroid artery. They are measured because the superior thyroid artery comes from the external carotid. Okay, this is the external carotid, this is the superior thyroid. And the inferior thyroid comes from the thyrocervical trunk. The thyrocervical trunk comes from the subclavian artery. That's why they are major arteries. Okay. As you can see here, the inferior thyroid artery supplies the inferior part, the superior thyroid artery supplies the superior part. Now why? And they create an anastomosis within the capsule over the gland. Now why is this very important? This is clinically very important because uh, in surgeries on or no before that, this is very important because every artery is accompanying one crucial nerve. Okay, so the superior thyroid artery is running with the external laryngeal nerve, okay, and the inferior thyroid artery is running with the recurrent laryngeal nerve. So the external laryngeal nerve supplies the cricothyroid muscle, okay, and the cricothyroid muscle is responsible for tensing the vocal cords in order so that we can make high frequency sounds. طيب. In case of cut or damage to the external laryngeal nerve, you will have paralysis to the cricothyroid muscle, hence no tensing of the vocal cords, and you can't create high frequency sounds. طيب. How is this related? How is this related to the thyroid gland generally? This is because in thyroidectomies, you have to ligate the arteries or the vessels generally that are supplying this gland. So in case which arteries should we ligate in thyroidectomy? We should ligate the superior thyroid artery and the inferior thyroid artery. So while ligating the superior thyroid, any artery of these, you can mistakenly cut one of the nerves that are running with either arteries. Okay, and this is a complication nobody wants because you will lose the ability to speak. Right. So how can we avoid this? It's basically by basically the external or the superior thyroid artery. The superior thyroid artery is, or before, no, the external laryngeal artery is very close to the gland. Okay, now let me show you this picture. So let me first orient you. This is the thyroid gland. This is the superior thyroid artery. They dissected it so that you can see what's behind it. Now, this is the superior laryngeal nerve. Okay, superior laryngeal nerve. Yeah. And this is the inferior thyroid artery, and this is the recurrent laryngeal nerve. As you can see here, the the superior laryngeal nerve is very close to the superior thyroid artery, where it is initiating from the external carotid artery. Okay, so if you want to ligate the superior thyroid artery, you should ligate it very close to the gland, because if you ligated it here or from where it initiated, you will damage this nerve. Okay, because they are very close here. However, close to the gland, they are quite far, and you won't do this mistake, and you won't have that complication. For the inferior thyroid artery, it's quite the opposite. Look at the recurrent laryngeal nerve. It's running in very close proximity to the gland and to the artery close to the gland when it's applied the gland. Okay, so if you want to ligate this artery, you should ligate it from where it is initiating. It's basically this is the external carotid artery. It's from under it, somewhere here. That's where you should ligate the inferior thyroid artery uh, away from the gland, because the recurrent laryngeal nerve is very close, very close to the gland, as you can see in this figure. And the opposite with the superior thyroid artery, you should ligate it very close to the gland, as as the superior laryngeal nerve is very close to where it's initiating from. Like, venous drainage is basically easy, usually 3 pairs of veins. It's just basic, just read it, you will understand immediately. Usually 3 pairs of veins drain the venous plexus on the anterior surface of thyroid, the superior thyroid vein and the middle thyroid vein. The superior drains the superior pole, the middle thyroid vein drains the middle thyroid vein drains the lateral part, and both these veins will empty into the internal jugular vein. Okay, and the inferior pole is drained by the inferior thyroid vein, and it will empty into the brachiocephalic vein. And remember, the thyroid gland has a right pole and the left pole, and the supplying from the arteries and veins is for both sides, so one for each side. So that's why here often unite to form a single vein that drains into one or other brachiocephalic vein. They mean here the left inferior thyroid vein and the right inferior thyroid vein will unite and drain into one of the brachiocephalic veins. Lymphatics, basically, they the prelaryngeal lymphatic nodes and the pretracheal and paratracheal lymphatic nodes uh, are responsible for the lymphatic vessels supplying the thyroid gland. The lateral lymphatic vessels along the superior thyroid veins pass to deep cervical lymph nodes. Nothing to be explained here. Basically, just memorize that all of these yellow are the lymph nodes that supply that drain, the thyroid gland, and then they end up directly into the thoracic duct. This is basically trying to introduce you to histology of the thyroid gland. What I've written here, I just explained it: the isthmus, the right and the left lobe. However, look at the histological cut of the thyroid gland. By the way, a very similar picture came in our OSP last year. This hole is called a follicle. Okay. The lumen is called the follicular. It's called the follicular cavity or the follicular lumen. The cells that are on the border of the follicle are called follicular cells. So these are follicular cells. In the middle, it is the follicular cavity or follicular lumen. And the follicular cavity or the follicular lumen contains the colloid. I will explain what's a colloid now in a bit. This is a blood vessel. Okay. Down here is the parathyroid gland. When we finish the thyroid, I will explain about the parathyroid, inshallah. Again, this is a quick histology. This is a follicle. Okay, so this is a full follicle. In the middle, it's the follicle cavity surrounded by follicular cells. Okay, and this is the septum, and this all is a lobe. Okay, it's wait. Yeah. So thyroid follicles are spherical structures filled with colloid, which is a viscous gel consisting mostly of iodinated thyroglobulin. Basically, this is the colloid sits in the follicular lumen or follicular cavity. What is the colloid? Colloid is a gel that has thyroglobulin inside it. What is thyroglobulin? Thyroglobulin is the first step into synthesizing the thyroid hormone. And I will be explaining now what is its importance in the synthesis of the thyroid hormone. But let me continue the histology. Follicular cells, I explained what follicular cells are. Parafollicular cells are I will explain about them in a second, but in the coming couple of slides. But they are cells that secrete. These are the parafollicular cells. They secrete calcitonin. Okay, and I will talk about calcitonin, inshallah. Again, this is a lobule. Okay, inside the lobule we have, and this is a lobule too. This is a lobule. This is a lobule. Inside every lobule we have follicles. Okay, and remember how every follicle has a lumen and for a lumen which is called follicular lumen or follicular cavity, and follicular cells. In the lumen we have the colloid. Okay, I want you to keep this in the back of your mind, because when I start explaining about the synthesis, when I will say colloid, I will say follicular lumen, you will know what follicular lumen is or what colloid is. Like the follicular cells can be cuboidal, columnar, or squamous, depending on the state of the thyroid gland generally. So normally it's cuboidal. When it is stimulated, it's columnar, and when it's inactive, it is squamous. This is a histology of an inactive follicle, and this is a histology of an active follicle. Okay. Physiology of the thyroid gland. So the thyroid gland, or a quick brief into it, the thyroid gland secretes thyroid hormone, which basically is T3, T4. That's what we call them. T3 and T4, you can see here, T3 triiodothyronine, and T4 thyroxine. What stimulates it? TSH. or thyroid stimulating hormone starts the synthesis and secretion of T3 and T4. TSH is secreted from the pituitary gland. Okay. Thyroid gland also secretes calcitonin that is involved in regulating calcium metabolism from the parafollicular cells. There are a couple of slides only dedicated for calcitonin. I will refer to them soon, inshallah. Okay. This is the molecular structure of both T3 and T4. The only difference between them is iodine. Now, I did not mention this. T3 and T4 is nothing but iodine. Okay? Iodine and tyrosine. This is the structure of a tyrosine. This is the structure of a tyrosine. On top of it is iodine. The only difference between T3 and T4 is one iodine. So T3 has three iodine molecules, and T4 has four iodine molecules. Okay. Right. Now let me start talking about the synthesis or the whole process of the synthesis of thyroid hormone of T3 and T4. So first step is thyroglobulin. Thyroglobulin has to be seated in the follicular lumen, okay, for the whole process to start. It is made in the follicular epithelial cell. We have thyroglobulin, and then tyrosine sits in thyroglobulin and waits in the lumen, literally waits in the lumen until iodine is supplied from the body. Okay, that's the first step. Taking thyroglobulin with tyrosine into the follicular lumen. Okay. The second step is bringing the iodine from the blood or from the plasma into the follicular lumen. Okay. Before I continue this step, I want to make sure that you understand what are we looking at. You need to be oriented. This is the follicular lumen, and this is the follicular epithelial cell, and this is the blood or the plasma. Right? So the follicular epithelial cell, you know how there was the follicle, and the follicle inside the follicle there is the follicular lumen or the follicular cavity. This is the lumen, and then around it are the follicular epithelial cells. Okay, this is the follicular epithelial cell. Right? Now we transfer the thyroglobulin with the tyrosine from the follicular epithelial cell into the follicular lumen. That's the first step. Okay. Second step, we need to bring iodine because, as I said, T3 and T4 or the thyroid hormone is nothing but tyrosine with iodine. So there is this transporter, sorry. It is called NIS, basically, NIS, which is sodium iodide cotransporter, okay? It basically transports both iodide and sodium from the blood. Okay, once iodide and sodium is in the blood, iodide should be oxidized to become iodine, okay? And this happens on the apical lumen of the follicular epithelial cell through an enzyme called thyroxine peroxidase. Thyroxine peroxidase, okay? Or peroxidase, oxidation. This peroxidase carries out three major steps. Oxidation, which is oxidizing the iodide, organification, and coupling. What are these? These are basically, first of all, these are the third, fourth, and fifth steps. طيب? Again, the second step is bringing iodide from the blood into the follicular epithelial cell. And then the third step is oxidation of the iodide and transferring it into the follicular lumen through the enzyme called peroxidase. طيب? This is oxidation. Now, iodide is oxidized. The fourth step is the fourth step in the whole process, or the second step for peroxidase, is called organification. What is organification? It's basically adding the oxidized iodine into the tyrosine on the thyroglobulin. Okay, so basically, in order for you to understand, I want you to imagine thyroglobulin as as the taxi for thyroxine. Okay, it is taking the ingredients step by step from an enzyme to an enzyme until we have full thyroxine, full T4 and T3 to be secreted into the blood. Right? So we had at the beginning, earliest step, we had thyroglobulin with tyrosine on it. Then we had peroxidase adding the oxidized iodine into the tyrosine on the thyroglobulin to form MIT and DIT. Okay, or mono MIT and DIT, or both. You know what? Just memorize them as MIT and DIT, and the coming slides we will explain what are they step by step. Okay, this is I'm here explaining it on one figure so that you can imagine it all in your mind. Right? The fifth step, this is the fourth step or the fourth step, which is called organification, which is carried out by peroxidase, which was adding the iodine or the oxidized iodine to the tyrosine on the thyroglobulin, forming MIT and DIT. The fifth step is called coupling. What is coupling? Coupling is also carried out by peroxidase, which is where the peroxidase couples MIT and DIT together to form T3 and T4. Now, what's the difference here? If we combine two DIT molecules, DIT and DIT, we will have T4. And if we combine MIT and DIT, we will have T3. Okay? And this is the product here in the lumen. Now, this product here will sit in the lumen, wait until its time come, literally. So it will be stored in the follicle, this product here, okay, which is the thyroglobulin or the taxi, alongside with T3 and T4, and some residues of MIT and DIT will be stored in the follicle or in the follicular lumen until our body needs thyroid hormone or needs some T3 and T4. Okay, that's when TSH will kick in and will activate the lysosomes, where they will the lysosomes, yes, where they will break down. First of all, before that, the thyroglobulin will be endocytosed into the follicular epithelial cell, and then the lysosome will be activated by TSH, and the proteases inside the lysosome will break down T3 and T4 from thyroglobulin and will secrete it into the blood. Okay. And then the remaining thyroglobulin and MIT and DIT will be recycled by an enzyme called diodinase. That's the eighth step, okay? So diodinase will break down MIT and DIT. I want you to recall with me, what are the residual MIT and DIT? They are only iodine and tyrosine, remember? So tyrosine and then oxidized iodine on it formed MIT and DIT. And then, so MIT and DIT is nothing but iodine and tyrosine. Okay, and then when they got coupled together, that's when we had T4 and T3. So diodinase will break down MIT and DIT into iodine and tyrosine. Tyrosine will go into thyroglobulin again and repeat the whole process. And the oxidized iodine will join the iodine coming from the NIS or the cotransporter into peroxidase in order to be added to tyrosine and repeat the whole step again. Okay, this is basically the synthesis of thyroid hormone in a nutshell. The coming slides will literally repeat what I explained, but in more details, and we'll add more stuff. See, look at step one here. It's the synthesis of thyroglobulin and taking it into the follicular lumen. It takes place in the rough endoplasmic reticulum and the Golgi apparatus. In the follicular epithelial cell, in the rough endoplasmic reticulum and the Golgi apparatus of the epithelial cell, thyroglobulin was made and then synthesized and then sent out into the lumen to start the whole process. The cotransporter here on the basal membrane, then oxidation. Look at 3, 4, 5. They are all carried out by peroxidase, oxidation, organification, and coupling on the luminal or apical membrane, all carried out again with peroxidase. They are inhibited by a drug called PTU. Just know that there is a drug called PTU that inhibits peroxidase. طيب? Oh, and here there is the transporter, the cotransporter in the second step is inhibited by a molecule called perchlorate. This step basically, how does that happen? Perchlorate basically is something that we have in our bodies, but why does it inhibit the cotransporter? Because or the transporting of iodine from the blood to the cell? It's because it competes with iodine for the transporter. So it takes the place of iodine in the transporter and gets transported into the cell and into the lumen and keeps iodine in the blood. So in that case, if we have so much perchlorate in our bodies, we will have iodine accumulating here in the blood and not transferring to the cell and into the lumen and starting the thyroid the whole process of the synthesis and not having T3 or T4 synthesized or thyroid hormones synthesized. طيب. Six is the endocytosis of thyroglobulin, which is this. I told you it is carried out when TSH kicks in and stimulates the whole thing. Hydrolysis of T4 and T3 by lysosomes. Lysosomes are also activated by TSH. They hydrolyze T3 and T4 in order for them to be secreted. The enzymes are proteases. Iodination by iodinase. I explained this step very well. Step 2, this space, you can read this. This literally repeats what I said. We can go over it really quickly. But it's basically the trapping of iodide. This is the NIS, the co-transporter of sodium and iodide, transporting iodide and then iodide through transferring into, this is the cell and this is the lumen or the cavity, okay, of the follicle. The iodide at this point, it's not oxidized yet, okay? It is taken into the lumen through this channel called pendolin in exchange with chloride, and at that point it is oxidized by peroxidase. Basically, that's it. They are telling you here about the thyroglobulin. It contains 70 tyrosine. You know, I told you how thyroglobulin is seated here with tyrosine on it, waiting for peroxidase to couple it with iodine to form MIT and DIT. Okay. Now, and this is just a continuation. It's basically saying 1 milligram per week of iodide is what we need for the absorption in the intestines. 1/5 of the circulating iodide is absorbed by the thyroid gland, and the rest is removed by the kidneys. NIS, the co-transporter, and an ATPase pump extruding sodium and excessive. Yes, this is talking about this. Just to, he's basically he's here trying to tell you that in order to balance the sodium levels in the cell or in the follicle, there is this channel right here. Step 3, which is oxidation and organification, both again carried out by peroxidase. Iodide is oxidized into I2 and I3. This step is called oxidation. They are then by peroxidase added to tyrosine in the thyroglobulin, and this step is called organification. Coupling, the 5th step, which is also taken care of by or carried out by peroxidase. This is the 3rd step for peroxidase. Okay, step 5, coupling. Coupling is basically binding of. So after we added the iodine to tyrosine, we formed MITs and DITs. Yeah, which are mono and diiodotyrosine or monoiodotyrosine, MIT and DIT. Now, coupling is basically coupling between MITs and DITs. Nothing. I explained everything here. Tyrosine is iodized to monoiodotyrosine and then to diiodotyrosine. T4 is the major product, which is 2 diiodotyrosines together. T3, which is 1 monoiodotyrosine and 1 diiodotyrosine, as I mentioned before. And okay, the 3rd product is a small amount of reverse T3. It has no function in humans, but it's just a small amount that is secreted by the thyroid. Good to know this. And then thyroglobulin may store up to 30 thyroxine molecules and few triiodothyronine molecules. This is basically the storage in the follicle itself until TSH or until our body requires some thyroid hormone and gets secreted. Step 6, 7, and 8 is endocytosis of thyroglobulin with MIT, with T3 and T4 and some residual MIT and DIT into the cell, and then lysosomes just hydrolyze T3 and T4 and secrete them into the blood, and then the thyroglobulin is recycled again to tyrosine. You can read it here. It's exactly what I explained, except for one point. Congenital absence of iodinase leads to thyroid hormone deficiency. This is iodinase here, recycling MIT and DIT into tyrosine and iodine. So if you don't have this enzyme, you will have thyroid hormone deficiency, because thyroglobulin is recycled more than it is made. Okay. This is basically a figure from first aid. You realize there are too many slides about the synthesis of thyroid hormone. This is because it's a very, very, very important process you need to know about. You will have many questions about this synthesis, and you will be asked many times. Okay, so you have to make sure that you understood it really well. Just I will go quickly over this just to make sure in hitting the nails, basically. Just to get oriented really quickly. This is the blood. This is the fire. This is the شوف, the blue and the purple part from here up until here is the follicle. This is the follicular cell, and this is the follicular lumen or cavity. طيب, this is the blood, and this is the peripheral tissue, which is the target tissue. Okay, this could be your heart, your kidneys, whatever. Okay, or your liver. It's basically the target tissue of the thyroid hormone. Step one, taking adding tyrosine to thyroglobulin and exocytosing it into the follicular lumen. Second step is having iodine and exocytosing it into the lumen, and then having peroxidase oxidize this iodine. And the third step is, or the fourth step is organification. برضو peroxidize, also peroxidize where you add the iodine into the tyrosine on the thyroglobulin. The product here is MITs and DITs. Then the fifth step is coupling, also taken care of by thyroid peroxidase. Coupling is basically adding MIT and DIT together to form T3 and T4. Again, T4 is two DIT molecules, T3 is an MIT and the DIT together. This is the product of coupling reaction carried out by peroxidase. And then whenever this is stored in the follicle, whenever we need it, it is endocytosed into the cell. Then the proteases in the lysosome will hydrolyze the T3 and T4 for them to be excreted in the circulation or the blood, and then MIT and DIT will be recycled by the iodinase. This T3 and T4 in the blood will go to the target tissue, and T4 will be will form T3, and I will explain why now in a bit, and will go do its effect and its function in the target tissue. Now, why does this step happen? Why do we have transformation from T4 into T3? And the enzyme is iodinase, by the way, 5' iodinase. This is because there is brief difference or slight difference between T3 and T4. So they function equally qualitative. However, they differ in the rapidity and intensity of the action. T3 is 4 times more potent than T4. And what do we mean by potent here? We mean that less amount of T3 is required to achieve the same amount or to achieve similar effect as a huge amount of T4. However, it's less present in the blood, and it lasts shorter than T4. This is basically because 90% of the output of the thyroid gland is T4 and 10% is T3. But this is an issue now because we need T3 as it is more potent, and this issue is solved by the target tissue. As you can see here, iodinase changes T4 into T3, which is the more potent or the more active version of thyroid hormone. Okay. This is just basically explaining what I said. Let's go over it really quickly. You see here the activity of T3 is 4 times faster than the activity of T4, and it stays more in the blood. Okay, so it's more active. See. Right. The next, this slide basically summarizes what's written in here. Just go over it just to understand, but I will explain on this slide. There's something called TBG, or thyroxine binding globulin. It is different than thyroglobulin in the thyroid gland in the follicle. No, this is different. This is in the blood. What is this? This is basically the protein that binds into T3 and into most of T3 and T4 in the blood. So as you can see here, thyroxine binding globulin, or TBG, binds most T3, T4 in the blood. Okay, And you have to keep in mind that most of the hormones that are bound to proteins like TBG, SPG, which is sex-binding globulin, or albumin, for example, these are bounding proteins. Whatever hormone that is bound to a protein is inactive, usually. Usually, the active forms of the hormones are the free ones in the blood. Okay, so most of the T3, T4 secreted is bound to TBG, and this form is inactive because this is the bound form. What is the importance of this? Now, we have some cases where TBG is increased and another cases where TBG is decreased. In cases of pregnancy or taking estrogen or contraceptive use, we have increased TBG. And if we have increased TBG, we will have increase in total T3, T4. How and why? Let me explain. Let me just put a pen and explain exactly why. So we have increase in TBG, yeah? Okay. If we have increase in TBG, this means we will have more TBG bound, more T3, T4 bound, so less active T3, T4, yeah? T3, T4, okay? If we have less T3, T4, this will be sensed by the pituitary gland, and we will have increase of TSH, which is thyroid stimulating hormone. If we have more TSH, we will have more T3, T4. This is a very, very, very summarized form of why we have increased T3, T4 in cases of increased TBG. More TBG, more bound T3, T4, so less active, forgive me, my handwriting is bad. Less active T3, T4, less active T3, T4, the TSH or the pituitary will sense, that there is no T3, T4, because I told you anything bound to TBG is inactive, and the pituitary gland senses the active forms of the thyroid hormone, hence it will be secreted as a negative or positive feedback loop, and will increase T3, T4 secretion from thyroid gland. And in cases of decreased TBG, such as in liver failure or steroids or nephrotic syndrome, literally the opposite happens. Okay. Now we will start talking about the regulation and TSH more. But I want you to read this slide really quickly along, because again, this right here summarizes what I explained here. Like, okay, really quickly going over it. I said TSH, or the anterior pituitary gland, senses the active form of thyroid, not the inactive form of thyroid, through the feedback mechanism between the hypothalamus and the anterior pituitary glands. How does this happen? Basically, I explained TSH, or thyroid stimulating hormone, increases thyroid hormone secretion. Yeah. But what increases thyroid stimulating hormone, TSH? It is basically a TRH, which is, it's mentioned somewhere in the following slides, but it's something coming from the hypothalamus, secretes TRH, which is, I forgot the name. How does TSH increase thyroid hormone secretion? By increasing proteolysis of stored thyroglobulin. The same way I mentioned, remember the step that was seated here? Thyroglobulin waits until its time comes. Yes, this is the step. Increase iodide pump activity, the NIS, the co-transporter that was on the figure seated right here exactly. The activity of this pump is increased by TSH in order to increase the iodine, in order to increase the synthesis of the of thyroid. Also, TSH stimulates peroxidase hormone, peroxidase enzyme, which takes care of iodination or oxidation of iodine and coupling it to tyrosine. TSH also increases the size of thyroid gland and it increases the secretory activity. This is very important. I will get back to it in a second. TSH also increases the number of thyroid cells and changes the shape of the cuticle or cuboidal to columnar to unfold into the follicles. So 3, 4, and 5 are very, very important things to keep in mind because again, TSH increases the size of the thyroid gland and it changes its shape. Okay. And this is normal so far. However, it could be pathological or it could be abnormal very easily. If we have too much TSH, then the size of the thyroid gland will increase to the extent that you can see bulging, and this is called goiter. And also, the shape of the changing of the shape of thyroid cell is called hyperplasia. Yeah, remember? And this is the negative feedback loop I was talking about. So if we have too many T3, T4, this will inhibit the anterior T3, T4, or the active T3, T4 will go to the anterior pituitary to inhibit the TSH secretion, as you can see, and it will also go to the hypothalamus to inhibit the secretion of TRH, which stimulates the secretion of TSH, basically. And the opposite, if we have less T3, T4, this will be sensed by the anterior pituitary and by the hypothalamus. Hypothalamus will secrete TRH, and TRH will stimulate the pituitary to secrete TSH. So that TSH can affect or stimulate thyroid follicular cells to secrete T3 and T4 the same way I explained it here. طيب, this is TRH, thyrotropin releasing hormone. Again, you see this in the pituitary, you know it. I will not explain it again, but it's basically through the TRH receptor on the TRH goes into TRH receptor in the pituitary, then it secretes TSH. Again, thyroid gland has a receptor for TSH. Once the TSH binds to the receptor, that's when everything starts, secretion starts and synthesis starts from the beginning. Okay. Yeah, this is basically it. Again, this is the same thing, just a repetition of what I explained, except the doctor here is trying to say in cyclic AMP is involved in TSH. Once the TSH binds to its receptor, how are those effects? Basically how are those effects taking place through cyclic AMP activating protein kinase A, which is increasing the phosphorylation of proteins and kicking in the synthesis and the secretion of the thyroid hormones and increasing its size and activity. Like, now we finished a huge pillar of the whole lecture. Now we are remained with the functions or the activity or the actions of thyroid hormones. Or basically T3, T4, or I like this figure. Look at it. It starts with T4. Basically starts with T4. Why? Because 90% of the output of the thyroid gland is T4. In the target cell, it is it changes into T3 by enzyme 5' deiodinase, and then T3 will bind to the nuclear receptor. Nuclear receptor what do we mean by nuclear receptor? This means that the thyroid hormone has an effect on the transcription of DNA and translation of mRNA, okay? It has an effect on the transcription and translation of DNA in order to have those effects on the body generally. طيب. Let me talk about them one by one and then going into details one by one. Let me start with BMR, the most important one. BMR is basal metabolic rate, or the calories you burn while sleeping. If you did not do anything today, you are burning this number of calories, of course, according to your body size and mass and height and weight and so on. You are burning this number of calories just by breathing, digesting, and basically your heart pumping and your lungs moving. Okay, you are burning this amount of. This is called the basal metabolic rate. طيب. Now thyroid increases this basal metabolic rate. How? By increasing the number of sodium potassium ATPase channels. If you increase these and you not only increase their number but also increase the activity of them, You also increase the O2 consumption. Yani if you increase this, you will increase the O2 consumption, basically. So you require more O2. Requiring more O2, yani more heat production. Okay? Remember mole? That's how you increase the BMR. So the BMR increases. Okay? And heat production increases, yani sweating, yani يعني the person or the patient cannot bear any I don't want to say hot environment, but حتى cool, not cold environment, they will not bear it. They'll be like, it's hot, it's hot. While it's very cool, they'll say it's hot, it's hot. This is because the thyroid hormone is increased. And this example, I'm talking about patients with hyperthyroidism, okay? On metabolism, or in the liver, basically, it increases glucose absorption. It also increases glycogenolysis, gluconeogenesis, and lipolysis. Okay. And it also increases protein synthesis and degradation. Remember, these four glycogenolysis, in order to breaking down of a glycogen, gluconeogenesis, creating glucose from nothing, and lipolysis, breaking down fat to use it as energy, and protein synthesis. They are catabolic effects. So the net effect of thyroid hormone is catabolic, not anabolic. Catabolic. Okay. On cardiovascular, it will increase cardiac output. How? By upregulating beta-1 adrenergic receptors, hence increasing the heart rate and hence increasing the cardiac output. Because if you remember, cardiac output equals stroke volume multiplied by heart rate. Alhamdulillah, I remembered it. So increase the heart rate, you will increase the cardiac output. And I remember, by the way, we had this as an SAQ in our exam last year. We had a patient, the SAQ, and then one of the questions were, why is the cardiac, or how would thyroid hormone increase cardiac output? Nervous system and growth. This takes place or takes action more in babies or infants while they are growing. In infants, thyroid hormone is required for the maturation of CNS. So I want you to imagine, if we don't have CNS, as an infant with no thyroid hormone will not be matured, will not have his CNS matured. Okay, so will cause some sort of retardation, and I will talk about this in the coming slides. Growth and bone maturation. Bone maturation, basically, because it has a similar effect of not only similar, synergistic effect with the growth hormone. That's why it increases growth and bone maturation. This is also takes place in infants more than adults. This is a picture from first aid. Amazing, a very nice mnemonic that will help you remember all of these actions of the thyroid hormone are remembered by this mnemonic 6 P's. So brain maturation in infants and bone growth also in infants, synergism with the growth hormone, beta adrenergic effect to increase the cardiac output through the heart rate, basal metabolic rate increase, which is the BMR, how? By increasing the sodium potassium ATPase activity, hence increasing O2 consumption and increasing body temperature. Increase blood sugar, how? Glycogenolysis and gluconeogenesis also will increase the blood sugar. Breaking down of lipids is by increasing lipolysis. Okay. And also remember, only free hormone is active. Anything bound to any protein is not active. Okay? Now, the coming slides will explain whatever I explained here in details. We'll just go over them really quickly. Thyroid hormone increases the cardiac output by increasing the heart rate. That's it, basically. Pharmacological control of thyroid hormone secretion. Basically, he's trying to say the doctor here is briefly touching over the drugs that control the thyroid hormone secretion, and here he explained where do they have their effect. So thiocyanate or perchlorate, I explained perchlorate, what perchlorate is. Thiocyanate has a similar effect of perchlorate. They inhibit iodide trapping. This is iodide trapping starts from here, from the co-transporter here. You trap the iodide by endocytosing it into the follicular cell, epithelial cell, and keeping it inside. So if we have our increased levels of thiocyanate for any reason, or perchlorate or nitrate ions, they will compete with iodide for that co-transporter, and they will take its place basically, and less iodide will be endocytosed inside. That's one. Two, PTU or propyl thiouracil. You know the drug that I told you, it inhibits peroxidase, and I told you just know that there's a drug called PTU that inhibits peroxidase. You're not supposed to know the drug specifically. That's just keep in mind that there is a drug called PTU or propyl thiouracil, and another drug called methimazole and carbimazole. All of these inhibit iodination of tyrosine by inhibiting peroxidase. So these three drugs inhibit peroxidase. Remember, peroxidase took place in three steps. First of all, oxidation, and then coupling, and then oxidation, and then organification and coupling. So it inhibits all of these. All of these drugs inhibit all of these steps because they inhibit one enzyme, which is peroxidase. And this step, or both of these, they lead into goiter. All of them lead into goiter, and I will explain how right now. So goiter is basically swelling. The swelling of the thyroid gland is called goiter. Right? We have goiter in the first. We have goiter. We have goiter in this step because less iodine is being endocytosed into the cell. Hence, less synthesis of thyroid hormone is taking place. Hence, we will have less T3, T4 in the blood. And less T3, T4 in the blood means will be sensed by the hypothalamus and anterior pituitary. So they will secrete TSH, or thyroid stimulating hormone. Thyroid stimulating hormone will keep on stimulating the thyroid gland until it grows. And because remember, one of the functions of TSH is increasing the size and activity and changing the shape of the thyroid hormone. So more TSH, and TSH is being secreted continuously because no T3 or T4 to negatively inhibit it. Why? Because we at the first place we don't have iodine to stop all of this, right? So the continuous stimulation from TSH will increase the size of the thyroid gland, and this increase in size is called goiter. Same thing for here. Peroxidase. We are inhibiting this step or this step, any of these steps. Hence, we will have less amounts of T3, T4 in the blood. Less amounts of T3, T4 in the blood will stimulate the pituitary to secrete TSH, and TSH will be secreted continuously while stimulating that. While TSH is stimulating the thyroid gland continuously, hence increasing its size, hence having goiter. طيب. يعني we can conclude basically any hypothyroidism case will have goiter so far. Okay. Finally, high concentration of iodides. Yeah, this is activity of thyroid gland is decreased for a few weeks to reduce iodide trapping. If we have very, very high concentrations of iodine in the blood, okay, this co-transporter will not work because it has to, it has to balance between it has to balance between or it has to keep the amount of iodine in the cell or in the follicle generally under some certain level. So if we have too much iodine here, this will stop. It will take whatever it needs, but it will stop because we don't need any more, because the cell will be full of iodine. We will not take more iodine. That's cell basically. Hence, the follicles generally will decrease in size because the gland is not being as active as before, because iodine is being trapped more frequently, basically. This is taking place here. So no endocytosis because of high concentrations of iodide. Diseases of thyroid. Let's talk about diseases of thyroid. If you understood the previous steps, okay, if you understood the previous steps of the normal physiology of the synthesis and the functions of thyroid hormone, the coming 10 slides maybe, will be very easy because you will just apply the abnormal state on the normal state you have in mind. So let's start with hyperthyroidism. We have many causes of hyperthyroidism. This includes toxic goiter or Graves' disease. Graves' disease, let me start with Graves' disease. Graves' disease is basically an autoimmune disease where antibodies, and these antibodies are called thyroid stimulating immunoglobulins, TSI, they bind to the TSH receptor. Why? Because they have a very similar shape or structure as TSH. So they can bind into the TSH receptor and induce continual activation of the thyroid gland, or basically the cyclic AMP system and so on the thyroid gland. So hence we will have very high levels of thyroid hormone in the blood, causing TSI to depress the pituitary gland secretion of TSH that drop to zero. What does this mean? We have an antibody stimulating the thyroid gland to secrete T3, T4 in very high levels over the time. Okay. Remember, the very high levels of thyroid hormone will negatively inhibit the anterior pituitary from secreting TSH. So if you draw a blood sample from a patient with Graves' disease, you will find their TSH to be very low, okay, or zero basically. Why? Because and their T3, T4 very high. Why is that? Because we are having an antibody activating the thyroid hormone, or taking the action of TSH basically. Right? Thyroid adenoma is another cause of hyperthyroidism, or basically cancer in the thyroid gland. So cancer in the thyroid gland will secrete large quantities of thyroid hormone, carrying out the same effect of the autoimmune disease here, or Graves' disease. Those large quantities of thyroid will inhibit TSH. However, the cancer will still be secreting will still be secreting thyroid hormone more and more and more. Okay. The healthy part of the gland will show reduction on thyroid secretion. So if you take the gland, the healthy part will not be secreting thyroid hormone. Why? Because we don't have TSH. And why do we not have TSH? Because the large quantities of the thyroid hormone from this cancer are inhibiting the pituitary from secreting TSH. And as you know, the normal or the healthy part of the gland requires TSH to work or to kick in. Okay, these are basically the causes of hyperthyroidism. What are the symptoms of hyperthyroidism? Basically, you see all the actions I talked about in the functions or the actions of the thyroid hormone. They are basically them, but on steroids, literally. So high state of excitability, you're always excited, and you can't tolerate heat. The patient cannot tolerate heat, sweating. You know all of these just by understanding the normal function of the thyroid hormone. Weight loss, varying degrees of diarrhea, muscle weakness, nervousness, extreme fatigue, but inability to sleep, tremor of the hands. Sorry, and this basically mimics the increased sympathetic activity, the symptoms of an increased sympathetic activity. Exophthalmos is another sign of hyperthyroidism. It is basically the protrusion of the eyeballs, as you can see here. Let me zoom in. Eyeballs protruded outside, eyelids going inside. This is basically called exophthalmos in people with hyperthyroidism. Okay, that's basically it. But this is here he's trying to say that exophthalmos is a main is a main sign or symptoms of Graves' disease or the autoimmune disease because of the IgGs. Like, how do we diagnose hyperthyroidism? By the measurement of free thyroxine, or T3 and T4 in the plasma, and TSH. So low TSH, okay, or close to zero, is as a sign of either Graves' disease or cancer. Yes, TSI, this is the Graves' disease. طيب. And hyperthyroidism is basically high T3, T4. So any high T3, T4 in the plasma means hyperthyroidism. How do we treat it? It's either by surgery, removal of the whole gland if there is if it's only an autoimmune disease, or if it's cancer, just removing the cancerous part. Or we can also use a drug. The drug is basically iodine. If a patient administers large quantities of iodine, that will be enough to destroy the thyroid cells. For the same reason I explained here, which is this. Okay. The thyroid with high iodine quantities, the thyroid gland will paralyze and become smaller. This is a quick. It's not a question. It's a scenario of a patient showing you what signs will they show up with of hyperthyroidism. So this is a 34-year-old woman with a 3 months history of fatigue, okay, weight loss, despite eating more than usual. So this is unintentional weight loss. Her pulse, very high heart rate, sorry, and her blood pressure is very high as well. Physical examination shows warm, moist skin, non-tender swelling over the anterior neck. Ophthalmologic examination shows swelling of the eyelid or proptosis bilaterally. This is a classical case basically of Graves' disease. One, we have unintentional weight loss. Okay, unintentional weight loss, high heart rate due to the one by one. Let me explain the symptoms one by one. Unintentional weight loss and fatigue due to the increased BMR. High heart rate, increased heart rate or tachycardia, basically because of the beta 1 adrenergic receptors activation. Increase in blood pressure for the same reason, beta 1 adrenergic receptors. Warm skin, increased intolerance to heat, and sweating is because of moist skin and sweating. Warm intolerance to heat is because of the increased BMR. Non-tender swelling over the anterior neck, this is goiter. And ophthalmic examination shows swelling of the eyelids and proptosis bilaterally. This is exophthalmos. This is the explanation of exophthalmos. The doctor will not tell you this patient has exophthalmos. They will tell you basically the findings of the examination. And this finding is called exophthalmos. These signs are signs of Graves' disease. Hypothyroidism is the opposite, literally. We also have those three causes. The doctor talked about them that cause hypothyroidism, autoimmune disease like Graves' disease, but however causing hypothyroidism. It's called Hashimoto disease. Hashimoto disease, it's an autoimmune disease where antibodies are developed against the thyroid gland, not activating it or stimulating it, but rather attacking it and destroying it. And so we will not have a thyroid gland, and we will not have thyroid hormone. Right? This results in inflammation and deterioration of the thyroid gland with the appearance of fibrosis and great reduction of the thyroid secretion. Hypertrophy of the thyroid gland can also lead to this is for the second part, sorry. So this is the autoimmune disease, or this is the Hashimoto disease. They are basically antibodies attacking and destroying the thyroid gland. If we will think about blood levels, TSH will be high. TSH will be very high because we don't have thyroid hormone to negatively inhibit TSH secretion. However, we don't have thyroid hormone at all. Hence, we will have the pituitary always stimulated and secreting TSH. Right? Here, the endemic colloid goiter or the idiopathic non-toxic colloid goiter are hypertrophy of the thyroid gland. Both of them are hypertrophy of the thyroid gland. However, they cause hypothyroidism. How? Endemic colloid goiter is caused by dietary iodide deficiency. We don't have iodide, okay? But this usually happens in developing country because in developed countries you don't usually have iodide deficiency because of their diet and food. Deficiency in the iodide will cause deficiency in thyroxine and T3 and T4, which will increase TSH by the pituitary gland, okay? It's basically self-explanatory here. No iodide, the same way I explained previously, no iodide, no synthesis, uh, no T3, no synthesis of T3, T4, no synthesis of T3 and T4 will increase TSH. Idiopathic non-toxic colloid goiter is associated with thyroiditis, leading to reduction of the size of some area of thyroid gland. So we have inflammation of the thyroid, causing reduction of the size of the thyroid gland, less thyroid hormones against stimulation of TSH, progressive growth of the non-inflamed areas of the thyroid hormone gland, causing goiter. Okay, so here in idiopathic non-toxic colloid goiter, we have healthy part of the gland that can grow bigger because of the TSH continuous secretion and stimulation of TSH to the thyroid hormone. Okay. Colloid goiter here is often associated with defective enzymatic system leading to less thyroid secretion. It's either iodide trapping in iodide deficiency or deficient peroxidase system. This could be the reason behind thyroiditis or the inflammation. Okay. The characteristics of hypothyroidism are the following. They are literally the opposite of the normal function of the thyroid gland. So this includes fatigue, somnolence, extreme muscular sluggishness, slow heart rate, decreased cardiac output, decreased blood volume, constipation, opposite of diarrhea, increased blood weight, unintentional increased blood weight, mental sluggishness, frog-like husky voice, basically opposite of everything we said in hypothyroidism and the normal functions of the thyroid. Mixed edema is basically a total absence of thyroid hormone function. So you can say it's okay, it's the total absence of thyroid hormone function. So it's a severe hypothyroidism. Okay, severe hypothyroidism, total absence of thyroid hormone function. The symptoms are, or the classical symptoms are bagginess under the eye. Look at the eye here, see bagginess under them, and swelling of the face. That's all you need to know. Hypothyroidism results in impaired metabolism of fat and cholesterol that increases atherosclerosis. These patients are basically, he's trying here to say, these patients are under higher risk of developing atherosclerosis because they have impaired metabolism of fat and cholesterol, because remember, thyroid hormone increases lipolysis. And this is a case of Hashimoto disease. A 39-year-old woman with type 1 diabetes mellitus comes to the physician because of 2 months history of fatigue and hair loss. She has smoked 1 pack of cigarette daily for the past 15 years. Her only medication is insulin. Her pulse is 59 per minute. Blood pressure is 102. And her physical examination shows dry skin, coarse hair, and non-tender diffuse neck swelling of the anterior midline. Again, all of the signs here are typical for Hashimoto disease, the autoimmune disease. Let me explain quickly why. So let's start with the pulse. Very, very low heart rate. Not very low heart rate. Not very, very low heart rate, but it's a low heart rate, bradycardia, basically. Why? Because of the absence of the thyroid hormone. One of the functions of thyroid hormone is activating beta adrenergic receptors. Same for the blood pressure. Okay, 2 signs now of hypothyroidism. Dry skin, coarse hair, and non-tender diffuse neck swelling. So dry skin, no sweating, not warm, coarse hair as well. Goiter goiter with hypothyroidism is a sign of Hashimoto disease or the autoimmune disease causing hypothyroidism. 70-year-old a woman brought to the physician by the son because of progressive memory loss for the past year. She feels tired and can no longer concentrate on her morning crossword puzzles. She has gained, that's one sign, first flag. She has gained 11 kilograms in the last year. That's unintentional weight gain. Her father died from complications of Alzheimer's disease. She has history of drinking alcohol excessively, but has not consumed alcohol for the past 10 years. Vital signs are within normal ranges. She is not oriented, but has short-term memory deficit. That's flag number 2. Examination shows normal gait, delayed relaxation of the Achilles reflex bilaterally. That's the 3rd one, delayed reflexes. Delayed reflexes are basically, you know how have you ever seen it in a movie where the doctor taps with a hammer on the knee and then the knee jerks off or kicks in? This is called a reflex, okay? If in our patient, we have delayed reflex in the Achilles reflex, not in the knee, in the Achilles tendon. So what is delayed? What do they mean by delayed? When the doctor tapped it with a hammer, it took a while until it kicked in, or it kicked in a lazy way, in a very slow fashion. Her skin is dry, 4, brittle nails, 5, which of the following is most likely the underlying etiology of memory loss? Hypothyroidism. Hypothyroidism is the cause of memory loss. An otherwise healthy 47-year-old woman comes to the physician for the evaluation of 4-month history of worsening fatigue and constipation. She also has noticed that her cheeks appear fuller and her voice has become coarse. Her temperature is 36. That's low temperature. Pulse is 59. That's low pulse. 2. Examination of the neck shows painless, mildly enlarged thyroid gland goiter, 3 flags. Her skin is dry. Her skin is dry and cool. 4. And her nails are appear brittle. 5. Serum studies shows antibodies against thyroid peroxidase. Antibodies against thyroid peroxidase. A biopsy of the thyroid gland is most likely show which of the following. This is basically Hashimoto, and the biopsy will show number of the number of follicles have squamous cell epithelium. Number of follicles will be, first of all, the follicle will be smaller and the number of follicles will be less, and they will have squamous epithelium. Remember, squamous epithelial or squamous follicular epithelial cells are a sign of an inactive thyroid gland. Okay, so this is Hashimoto basically. And remember, antibodies against destroying or attacking the thyroid gland or any part of the thyroid gland is Hashimoto. Treatment of hypothyroidism, screening hypothyroidism, daily oral intake of thyroxine. Give thyroxine to a hypothyroidism patient, they will become normal. Patients with mixed edema can also be treated with thyroxine. This is a table summarizing the differences between hyperthyroidism and hypothyroidism to make your life easier. And this is from first aid as well. Differences. Causes of goiter, we talked about them: Graves' disease, autoimmune disease causing hyperthyroidism, Hashimoto or thyroiditis, autoimmune disease causing hypothyroidism, iodine deficiency, TSH, all of these cause goiter. Cretinism is basically hypothyroidism in infants and childhood. Same symptoms, except they have also retardation of growth and retardation of mind. Why? Because, or mental growth retardation, basically. Why? Because remember how thyroid hormone has a function or an effect on brain CNS maturation and growth and bone maturation. That's the end of the first part. That's the end of my of the thyroid gland. Now into the parathyroid gland. For that,